fear but fear itself. So the Essentials course, TeamSTEPPS. Oh, it must be in a different hot mic spot. Okay, anyway, am I okay? All right, so I want you guys to go to AHRQ, and you're going to find TeamSTEPPS on that. There's a workbook. I used to bring the workbooks in, but they all go like $10 a piece times, and then I get like 4 back, right? Like somehow the students think they're going to ever use it again. But anyway, just go online. It's free. It's there. And when you guys do your group work, so go there early, because when you do the group work, you're going to use that as a resource to answer the questions and the scenarios when you guys come up with amazing, smart things. Oh, I haven't hit the button. Did you? Okay. So anyway, so once you guys get there, give a chance to get there, just work your way towards it for the TeamSTEPPS. And then you're going to see not this PowerPoint, but I want you to find the booklet, the pocket guide. So I'll cover the content, and then you use the pocket guide conceptually when you guys do the group work. Because there are going to be multiple scenarios. And in the scenarios, you guys are going to use the rules and TeamSTEPPS to break it down or define what went right and what didn't go so right.
Is it only as an app?
No, it should be as a straight-up web page. There you go. Okay, so let me just tell you background on TeamSTEPPS. Who's heard of TeamSTEPPS before? Raise your hand. Really? Who's done SBAR before? Raise your hand. Guess what? Those are tools that are actually from TeamSTEPPS. So, and a lot of places think if they do. Who's heard of a huddle before at the VA? Raise your hand. That's TeamSTEPPS. All right. So, who's heard of a lawyer before? Raise your hand. Those are the people that don't use TeamSTEPPS. Those are the clients. So anyway, so the background on this, we started this back I got involved in the 90s. In the 90s, it was called Med Teams back then. And the reason how it came into development was in the late 80s, early 90s, there was a lot of aircraft crashes because we changed platforms. Our aircraft, our Air Force aircraft had changed platform, and the Army had gone from the Huey to the Black Hawk. Best known at the time when it first came out was Crash Hawk. And with that happening, the issues at hand were we had a lot of accidents, but when they looked at it, the machinery was fine. It wasn't the machinery that was the issue. It turned out it was the crew communication and response between the pilot and others to keep the aircraft flying. So they came up with research, the Dynamic Research Corporation put together a safety check package. So we no longer make assumptions. Even if you work together all the time, we still state the checks as you go through the process, right? That's where you always hear that fuel switch on, right? And they repeat it back and forth because it would hopefully work. And then they did research with it because then there was groups that called regimental flying. And the issue with that was the crews that always flew together thought they were better. And it turned out they actually weren't, because if we all fly together, like say you and I are in the same crew, right? So obviously you check the flaps because that's what you do. I didn't ask you. But if we didn't know each other, we'd follow the checklist. Did you hit the flaps? Hit the flaps, right? Back, forth. So the crews that thought they worked together, they liked each other better, but they didn't fly more efficiently, actually more at risk. So knowing each other was a deterrent, not a plus. So the checklist then was implemented by the Air Force and the Army. And their crash ratio went from unacceptable 6 or 7% back down to 0. Both of them, Army and Air Force, at 0 when they followed the safety program. Now the Air Force, those of you Air Force, raise your hand. All right, good. So don't tell them. But here's the deal. They obviously, a new general came in, and most of the generals in the Air Force, regardless of qualifications, are usually pilots, tend to be pilots, and not the medical corps, but in hardcore Air Force side, space and air command. So the pilots are like, hey, we don't need this checklist. We're professionals. So they actually got rid of it.
That's not true.
Yes, it is. Is he a pilot?
Yes.
He's going to be a general one day. And so anyway, so here's the deal. He will be. You watch and see. And he's going to kill their safety program. So anyway, so what happened? So what happened was they got rid of the safety checklist because they thought their prior service issues that they were doing were fine. And so we basically indirectly created a hypothesis, a null hypothesis, because then the Army takes way too long to make its mind up and change things. We just kept it even though they didn't want it. So the safety record stayed the same. The Air Force, within about 6 to 12 months, started eking towards their previous numbers. So then another good pilot came in and fixed it and said, we need to implement that again, and it's still there to this day. They do the checklist, and again, their numbers dropped. Now, that's great. You're like, what does it have to do with nursing? Nothing. No, absolutely everything, because in emergency care, same thing happens. You have like an emergency room physician. You have basically your nurse is really your assistant pilot in most cases. And then you have other folks within the department, paramedics and techs, are kind of like your crew chief. And they figure everyone, well, the ER doc knows what he's doing, or the surgeon knows what he's doing. So everyone just kind of let them go on, right? And then errors occurred because no one said anything because he's the expert. So we had a high error rate as well. And this is around the time I had been in nursing long enough where I was probably, as a nurse, emergency room nurse, probably 5, 6, maybe 7 years at this point. So you will obviously see people that you respect. Physicians and nurses were going up against peer reviews, and some of them are getting sanctioned, some of them lost their license, and you're like, wow, it's not because they were a bad clinician. They were not a bad clinician at all. They were actually very good, someone I respected, but they got caught in an error. And anytime there's an error, someone's head has to practically usually get put on a post for everyone to see what happens if there's an error. So you're like, at this point, you're like, it's just a matter of time. You get this sense that we're always stressed, we're always stretched beyond our capacities, and people are making errors, and then they basically, get bled out. So this is when opportunity came up where they had med teams. It was being fielded initially with the military, and Congress liked the premise of it. Dynamic Research Corporation moved it to the medical model, and Congress actually started to fund this independently. A couple $1 million were initially thrown at it. And nobody knew what this med teams was. I was a senior captain, so I didn't want it, but everyone else said they didn't want to do it. And I was junior enough that I couldn't say no, but I was senior enough that I had to do it next. So serendipitously, I got attached to this med teams thing. And it was the most amazing thing that happened to me, because I went to Boston to the Colonnade Hotel. In that room, Lucian Leap. Have you guys done Chasing Zero yet? With Dr. Richardson? Chasing Zero, that's with Dennis Quaid, where his kids initially had that error at the heparin. Well, Lucian Leap, who's like the expert on error management, who's like a cardiothoracic pediatric surgeon and about 7 other qualifications, like got the eyebrows like twice the width of his head, he's a wise man. I got to study under him. Matter of fact, when they went through the room, people at the table all had minimum of a master's degree, double PhDs, double-seated in all their areas. I was unfortunately the last guy to introduce myself in the room, so I just started pouring water. I didn't even say my name because I had a bachelor's degree. I was the least qualified person to be in the room. But they embraced me, and I learned how to do really good PowerPoints because I was low on content. So even with really smart people, if you make things flutter on the screen, they get excited. So anyway, I got to be part of this. We went to Palm Springs, Washington, D.C. It was a couple of years. And we grew this project called Med Teams. And once we went live, we had 5 civilian hospitals throughout the United States and 5 military hospitals. So we had 10 hospitals, so 5 of us went live, initially with the best guess in what we were going to do for these checklists, communication, movement, and accountability, all these rules we're about to go over, and we went live. And our error rate dropped down to like less than 3% of potential litigious events from 15. We're like, that's really good. That's really, really good. And then we went ahead and had the other hospital go live, because then we had lessons learned, tweaked the program, and then everyone went live. Well, the second group had even higher results. They had reduced their errors by greater than 85% by utilizing this program. So with that said, obviously, it's a good thing. But that was just emergency care. Because remember, if someone's having an MI, and that was the errors you would see. Like the medic, or a tech, or the nurse would get an EKG, and you would see the classic tombstone rhythm, right? That's a bad thing. And the doc's over here suturing. You go, hey, we got a bad EKG. Put it in the rack. They put it in the rack, and and the doc would continue to suture, for another 20 minutes. In the meantime, right, time is myocardium, so the infarct would increase because no one would further interrupt because there was no process to interrupt. So they just put it in the rack. And then the physician, upon his own or her discovery, would grab it and figure out what they're going to do next. Well, this program we're going to talk about creates linchpins where we have to close communication loops and we have to crosstalk, and everyone's accountable at all levels. So there was a lot of resistance to TeamSTEPPS when we brought it in. Sal Wamsgan, Dr. Wamsgan, Mississippi, he was an audiologist first, and then he became an ER physician. Great guy, but he was resistant. He's like, Jim, he had a Mississippi accent. Jim, if I need a nurse to do something, I tell them what to do. And if they do it, everybody's okay. And I said, you are so flawed in your thinking, because I did not tell you to say that. Right? So anyway, we were talking, we implemented. So he was in resistance. And then it was only 4 weeks maybe into it, he comes into my office and closes the door, like real secret squirrelish. First thing he says to me, I'll deny we ever had this conversation. I said, so far, so good, and he goes, this TeamSTEPPS thing, or med teams, this med teams thing, excuse the language, he goes, it saved my ass twice this week alone. And I said, you mean the patient's ass? He goes, I don't care how you want to rank order it, I still got my license, right? So the fact is, someone that was resistant to it saw the value immediately within short implementation, because the culture hadn't changed, right? Thinking Lewin's force field model, we identified a problem, we were kind of in the moving. Most of you did pretty good on that one, by the way. Congratulations, real impressed. But anyway, we were in the moving phase, and even then, we were actually having great results early on. Now, with that said, it's now been morphed because Dynamic Research Corporation created consulting. Remember, we talked about consulting. We'll talk a little bit about organization structure, too. But they were consultants. So they came in and were making millions and millions of dollars off of this product that Congress funded and the Department of Defense helped develop. So AHRQ is a government function. They're like, wait a minute, we already paid for this. And they were going into the VA initially, charging the VA system millions and millions of dollars to pay for their consulting, when in reality, it's already been paid for once by the government. So that's when it split. It became TeamSTEPPS instead of med teams. Dynamic Research Corporation was allowed to keep the modeling, but they've been bought out about 3 years ago. They no longer exist because this is a self-implementation program. If you want to put it into your services or your facility, there are mentoring DVDs, videos, all the paperwork, all the research. Everything you need to implement this is there, the full comprehensive package. So it's free. It shouldn't be charged for because it's about safety and improvement processes that literally save lives. Okay, there's the precursor. Welcome to the essentials of TeamSTEPPS. So there's a model, right? Somebody obviously did their PhD. So they got a model. And here you go. So one thing in the center, when you see that, it's like a target, right? That crosshair, that's your patient. That's your patient on that crosshair. And then you have leadership, communication, you have situation monitoring and medical support. That's the model of TeamSTEPPS. Remember I talked the other day about things you bring to the table. Right? Decision making, you being the best you can be. Knowledge, attitudes, and performance, they're outside the circle because that's the hire. That's you. That's who gets brought on to be that nurse or doctor or tech in their zone. Those are the things you have to bring to the table. So in the interview, that's what we're going to look for. Your ability, your knowledge, your attitudes, and performance. Now, if you just pass NCLEX, how much knowledge are you bringing to the table? I'm sorry. How much are you bringing to the table? Huh? You're bringing basic competency. Basic competency. So the part that's really going to win us over is your performance and especially your attitude, which means everything really, right? Your willingness to learn, participate, and how you're going to interface. And are you going to use a social or an emotional intelligence quotient for that, right? Those are the things they're going to look for because what you do and bring to this model is going to really make or break the program. Make or break the program. So there it is. So that circle is what? That's the entire care team. Now, we'll talk about the elements of the care team. It's beyond just the bedside, but the bedside in TeamSTEPPS is the most important component, and it should be. The work you do as nurses bedside is by far the most important work that occurs in patient care. Yet, you know, it's the quiet, that's the one we don't talk about enough. Everyone's wanting to become a suit. Everyone wants to become a practitioner. Really, you guys are really in the next year are going to probably do your best and most honest work as nurses. So here's what we get, right? We reduce clinical errors. Good thing. Improve patient outcomes. Good thing. Improve process outcomes. It's a good thing. Now, remember, everyone has to be involved here. We said bedside, but let's go ahead and branch out for a second. Your admin team has to be there too. And what gets them, because remember, it's expensive to train TeamSTEPPS. Look around this room, multiply it by 10, because that's how many nurses are in a small hospital. And then if I pay you $25 an hour minimum, plus shift differentials, how much is it going to cost for me to do an 8-hour block of instruction to get everyone, right? So that's hundreds of thousands of dollars to teach. At first they didn't want to do it. They said it's a great idea. But now you reduce clinical errors. So hundreds of thousands of dollars to train and change your culture. But one lawsuit can cost millions and millions of dollars. So that becomes the upside from the administrative support side. How much money can they potentially save? Well, if it reduces litigious events by 85 to 90%, obviously we're talking millions and millions of dollars per institution. So increased staff satisfaction. Is there dollar added to that also from the administrative side? Right? It's going to cost anywhere between $65,000 and $100,000 to onboard every single one of you in this room to the facility. So if you walk early, they not only paid your salary, but they also lost money in processing. And also, Hertzberg's, right? Theory, what's Hertzberg? What would that be? Satisfaction. Is it hygienic? What is it?
Hygienic and motivation.
Is what?
Hygiene and motivation.
There you go. Very good. He must have been to the water cooler, one of 4 people. But anyway, so here we are, moving on. All right, so key principles. So we're going to talk about team structure, leadership, situation monitoring, mutual support, and communication. Each one of these has components to it that we have to understand. And these are the things you're going to use to solve that scenario coming up. So you see off to the side of the pyramid of life, right? So you have administration. Then we have the coordinators team. What is that coordinating team? Who would that be? PCC. Well, it's actually going to be... Coordinating team is going to be your nurse manager, charge nurse, anyone that's involved. Does nurse managers walk around with the clipboards? Right? You all go, I won't be that person one day, right? And then ancillary support services. Now that's like your blood lab guys, x-ray services, respiratory therapy. And then the core team is that bedside team. And then, of course, the patient is the tip of the spear on that. And then the contingency team is going to be, at the VA, they call it a what? The emergency team. What do they call it? DART team? Yeah, DART. And then everywhere else they call it rapid response teams. That's your contingency. And it can be a code team as well. It can be a code team, but hopefully in a good, safe environment, it'll be a rapid response team because the patient shouldn't have to code before they get additional care. So leadership. That's why you're here, right? So organize the team. You have to have clear goals. Make decisions through collective input from members. What type of leadership is that? Democratic. Excellent. You guys are right on it. So it's, thank God it's not a comprehensive exam. Anyway, empower members to speak up and challenge when appropriate. Again, that's democratic, and that's how it's become safe. And then promote and facilitate good teamwork. So again, that's transformational leadership. That is using Hertzberg motivation theories and everything else, and then skillful at conflict resolution. Because remember, we said conflict's good, right? We agree? It's when it's not attenuated and controlled is when conflict becomes negative. Because conflict means we have double sets of optics at a minimum, and we have to resolve that conflict, and usually it's in the middle somewhere that'll actually increase the product. So there's going to be planning, right? This is the brief. Now, those of you who are at the VA, who's at the VA, raise your hand. Everything's a huddle there, right? Okay, it's really in the morning. It's like a rose. I guess it still smells just as sweet by another name, but it should be called a brief. And it's important for testing purposes, and just because you're human beings, you need to understand that a huddle is an ad hoc, not a planned meeting. And so let's just say we have a brief. This is the morning. We're all going to do, you got so-and-so patients, you have so-and-so patients, you have so-and-so patients. We're expecting 4 admissions. You'll pick up the admission. You have 2 discharges. I'll help you with discharge by noon. All right, that's our brief for the morning. Well, the emergency room calls. There's going to be 3 additional patients coming upstairs. 1 is going to be discharged early because they got to go to rehab and the window's opening, so now our workload just shifted. Now we have to have a quick meeting called a huddle to realign how we're going to handle that workload change or situation. And then the debrief, we'll talk about that in length, but the debrief is very important. That's how you close out your day. You just don't go home frustrated and then just come back the next day more frustrated. Oh, hit the wrong button. Okay, good. So here's a checklist. This checklist isn't necessary, but it's really nice when you're implementing things into a culture. You give someone a construct in which to work with. And here, so you ask, who's on the team? You write that down. All members understand and agree upon the goals. Check that, right? Roles and responsibilities are understood, and how do we do that? With even patient teaching. How do we tell if it was effective? Teach back, right? Absolutely. And then workload among team members. Is it fair? Right, this is where we talk about it, because sometimes someone gets a whole bunch of stuff, somebody doesn't have a lot. This is where we have the conversation before you're in the middle of your shift and you've just had enough. And then availability of resources. What do we have on reserve, or what are we short? And let's get busy.
Okay, she currently only has intermittent late decelerations, and these have improved with her position changes and supplemental oxygen. We'll monitor her until she's fully dilated and allow her to push. If there's any evidence of fetal distress or persistent late decelerations, we should be prepared to go to C-section.
I've alerted the OR to be prepared in case we need to use it.
Great. I'll discuss this plan with Mrs. Keys when we're done here. What are her vitals right now?
Normal, just checked 15 minutes ago.
She's had no late deceleration since you recall.
Let's continue to monitor her. I need to know when she's complete and pushing so we can keep a close eye on her second stage. Any questions?
Sometimes the video works, sometimes it doesn't. Sorry. Anyway, the debrief checklist. So at the end of the day, before you go home, this was really important in the military side of the day. Who is a medic in here? Anyone? So the medic, did you work in a hospital? So you're always in the field, right? Sitting in the motor pool most of the time, right? Okay. So, I mean, that's where medics are extra mechanics. So, and then you go to the field and you have to do everything and be a medic and carry twice the load, right? Yeah, fluids and everything else, right? Yeah, hoorah. So anyway, the medics in the hospital loved it because you had nurses and docs who are officers. The medics are traditionally going to be enlisted or NCOs. And a lot of times by the model, you don't get a lot of feedback opportunities. So they love the debrief. Before we go home, the medics actually would hold this form. No one was going home until we did a debrief. The nice thing about it was the debrief started holding accountability of workload. Yeah, I mean, you guys probably even see it in the regular settings where there's some nurses kind of do everything from the stool. They somehow manage to slide around the nursing station but never step outside. Still, patients are taken care of somehow. Right? Well, those nurses get called out pretty quick on this checklist. So initially, it was kind of brutal, but no one was hollering, no one was being derogatory, but just to hold up the mirror and let people know that they were not doing fair distribution of workload was pretty meaningful. By about 2-3 months into the process, no one wanted to have that negative appraisal. So they would say, Tom, will you get a... Never mind, I'll get the urinal myself. Because a lot of times, like, Tom's across the room, the urinal's right there, and they would actually ask a medic to get the urinal for a patient. Suddenly they would catch themselves grabbing it and then moving it to where it needs to be, probably another 4 feet away. So that's how it works. And then situational awareness, we'll talk about that. That's how we cross cover and being aware of what's going on in the environment. The checklist, after about 4 months, I still had these stacks of checklists because everyone loved them. I stopped reading them. I just started storing them, and then when my drawer filled up, I started shredding them because they still had accountability, but it was internal accountability. They didn't need me to come out and tell them to behave. They were doing it themselves. It was normative. What's the term? What? Yeah, normative reductive, right? Normative reductive. They were holding each other accountable, which is a healthy work environment.
Great job, everyone. Can we discuss how things went today with Mrs. Keys? What did we do well, and what can we do better next time?
It was helpful for me to be brought in early. That allowed me to use a regional instead of a general anesthesia.
You're right, Brad. Lynn, what did you think?
It was great that Dr. Dean helped put the Foley in place while I did the count with Alicia.
Albert, this is a great example of task assistance. How was our communication today?
Excellent.
Team debrief. Okay, the team debrief was this. The video, he's like, hey, you guys did great. There it is. So, situation monitoring. All right? So, watch the graphic, stare at it. Now, don't touch your TV set. Anyway, situation monitoring, situational awareness, and shared mental model. These are the three components that keep you informed of what's happening. There's somebody on the nursing service that does this already. They're called the clerk. You walk up to the clerk, where's so-and-so, they know where you're at, right? They know what's happening, they know who's coming up. Everyone should have that level of understanding and knowledge of what's going on. So you understand, if you're going to go in, say you're going to do a Foley, or for you guys, you say you're going to do an IV on a patient, so you'll be off the floor for half an hour, right? Okay. Right? You know the IV dance and pat, 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 put the tourniquet on and off, right? So anyway, you will be down to doing it in 40 seconds one day, not 4 hours. So anyway, the point is you're doing a tasker, and obviously you're focused on a task. So there has to be a way to leave the room and be able to plug back into the ebb and flow on the floor, right? So you somehow have to understand what's happening and know what's going on with other colleagues. And you should be able to do things. We'll talk about task assists as well. So cross-monitoring. It's an error reduction strategy. You monitor the actions of other team members. So even though I'm taking care of my patient over here who's getting pre-op, I can tell that you have a patient right now who's angry, very angry, and inappropriately raising his voice at you because there's probably some delirium, right? But so my patient's pre-op, everything's done. Do I just say it's tough to be you? Or am I aware that maybe we need to, like, I do know that you're there, that the family member is good at calming the patient. So I go get the family member and bring him in the room to help you out, even though my patient's here. So I'm monitoring that I can help it and watch each other's back. It's really important to know that you're watching each other and helping each other. So situation monitoring. This video, so on this one, who's a med tech. He's going to draw blood on this lady. And he knew her because he draws blood on her every day. And that day, she starts talking about her cat, like arbitrarily. Instead of going, wow, that girl's cray-cray, right, and left the room, he actually went to the nursing station and talked to the nurse who was doing something else and said, hey, have her contact me. I'm really concerned about the patient. And then when he did, it turned out the patient was becoming septic. So his crosstalk with her saved the septicemia from occurring. These videos, by the way, are all online. So here's a nice little thing, like mnemonics, right? STEP. So when you're going to do a brief, not just SBAR, just real quickly on the floor. So status of the patient, who are the team members, what's the environment right now? Hey, we're really crazy, we're busy. And then progress towards our goal. We got 3 more admits to do. We have housekeeping that's not here yet, so we're going to have a minor delay. Blah, 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 right? That's STEP. Now here's another checklist. Now, again, it's up to the area. You can refine this checklist. These are just out here to help guide what you want to accomplish during that timeline using the mnemonic. So what's the status of the patient? Those are the things you're looking at. So it helps you kind of focus on what you're going to look at. What's the team? Are we workload? Our skills are all there? That was one of the questions on the test, right? ICU nurse floats down. What kind of skills, right, is she going to get? What kind of patient, right? You all know that question? A lot of you wrote about it too. So anyway, so this is that device right there, right? And then the environment. So what do we have for equipment? Say the ACLS cart was used that night shift. It was taken down, but a new one wasn't upstairs. Now, it's a life safety issue. Now, you probably won't have any codes on the floor, especially if you're med-surg. But should you continue to not have a crash cart on the floor? It's a life safety issue, so it has to be on the floor. So just an example there, you'd have to make sure you chase that. And then progress towards goal. It's self-explanatory. Now this is an important one. For peer review, if you don't ask this of yourself and you have a problem on shift or an error occurs, this is what they're really going to do for you. I'm safe. Am I ill? Am I taking medication? Am I under stress? Alcohol and drugs? And drugs doesn't have to be recreational. It can be, tons of stuff. If you're taking anything, right? Let's say you have a Percocet because, you hurt your ankle or your toe got operated on. And you come back to work, so you took a Percocet. Are you completely clairvoyant, even though you feel you are? Right? Probably not. You need to communicate that. And then eating and elimination. Well, has anyone ever had diarrhea before? Raise your hand. Right? So anyway, so those of you that have a friend that had diarrhea, and they probably told you it's really uncomfortable and you have to go to the bathroom a lot. Now think about it. If you're an OR nurse and your friend has diarrhea, think about it. Right? And she's in the OR or he's in the OR, and it's a 6-hour case. And you know your friend's not going to make it more than 30 minutes at a time. Do you not need to communicate that? Or do you just act like you don't notice anything on the floor? Right? I don't know where that is. Right. So anyway, I am safe. Especially in the emergency room, the biggest issue is fatigue. A lot of times it's fatigue. And that is just as dangerous. You see it all the time, right? You see that where like texting and driving and drinking and driving is bad, but fatigue driving sometimes is even worse. It's sometimes even worse. So fatigue in the healthcare environment, being really tired is not safe. And the thing is, you can tell someone that you're not tired. That you're very tired. Because when I've had errors occur, traditionally it's a fatigue issue. Vigilance drops off. You're not paying attention to trends until they're so obvious. And that's the big one that'll get you. And that's the one you're going to most likely not call yourself out on. Mutual support. So, and now we're talking mutual support, what are we looking at? Can someone help define that looking at this? What is mutual support? Right, absolutely. Right, that's huge. And that's the biggest issue. When you do the debriefs, workload inequity is usually the biggest source of conflict. And when you help someone, it pays off. Now, who's been at Methodist in the PACU? I got to say, the PACU, without having TeamSTEPPS in their life, looks like they've been trained and honed on TeamSTEPPS. They kind of like drift. The patient comes in from the OR. The patient comes in. The nurses are over here. They make sure everything's good, and they drift towards that other patient without even talking to each other. One's grabbing the oxygen, connecting it over to the wall unit. The other one hangs the IV up. Someone else is moving on the other side, get the patient situated. And then when their tasks are done, they just float back to their patient. That is a beautiful thing. Really was nice to see, and they were consistent with that. That's their environment of care. It just so happens they rock it. Now, feedback. This is really important. How do you change a culture? It's not going to change in a vacuum. You have to cross-talk to each other. You have to give each other feedback. But look at, we're saying it should be timely. If I did something that bothered you a week ago, now is not the time to have that conversation. So make sure you bring it in as close to the time it happened as possible, and then be respectful about it. And that's the biggest issue, especially in nursing. I tend to see nurses sometimes don't feel empowered, so they are not always respectful. If they feel that they've been on the floor longer, they're a little more senior, they just come down on that individual. Well, be respectful at all levels, because otherwise it creates a hierarchy that need not be there. That hierarchy need not be there because, especially in the military, that was always my counseling thing. By the time I was senior in the military, I would see one of my colleagues, another colonel, go off on somebody that was either a young officer or an enlisted guy. And I'm like, so I would walk away and say, what do we get from that? Oh, he was a dirtbag. I said, not really. He maintained composure and was respectful the entire time. You said everything and anything you wanted to say. You were disrespectful, The person that was actually had the higher hand here was that individual that maintained discipline during that engagement. You just let loose. You were out of control. It was wrong. I'm sorry you feel that way. Well, it's not a matter of feeling. It's what I saw, right? And people actually have that conversation. It's very powerful. It's called having crucial or difficult conversations. And you hold each other, and we, trust me. Yeah, you guys know Braulio? Braulio, do you not hit me with stuff? Yeah, he does. But you know what? Sometimes it's very much necessary. And I would hope I respond, other than just shut your face, right? So anyway, the point is we have to have that. That's how we grow, and that's how teams work best together. Teams work best together that way. And then, of course, be considerate. And then, if everyone knows they're coming from that place, it's a lot easier to have that difficult conversation because it's not vilified. It's not hatred. It's about self-improvement and organizational improvement. As long as you hit it from that point, it really is fairly benign, and it's always shaping and insightful.
Hey, Hal. Good job with Eddie earlier today. Our communication was precise, and we got him the necessary attention quickly. Good job.
So that's feedback. Now believe it or not, though, that's what was that? The two worst words is good job. What movie was that? Where the drummer? Whiplash, yeah. Well, I disagree. Good job goes a long way. And he smiles, right? What happened in this case was the doc was busy doing something else, and he was worried about one of the chronic patients that came in all the time with chest pain. And the doc goes, I'm busy doing something right now, and he was. So he said, you know what? I need you to go over here and now. So it ticked him off initially. He's like, duh! And he goes over and realizes the guy was having an MI for real. This is a chronic patient, but this time he's having an MI. And he had to call cardiology, and the guy had to go up for a stent. So once everything happened, the patient went upstairs. That was his feedback. Good job. It's really important to let each other know you did a good job. It's nice to hear from someone you respect that you work with, good job. It is. It really puts a little extra wind in your sail. So advocacy versus assertion. There's a difference here. There's the other big B word, right? That's not on here. Don't let it get personal, and don't get creepy angry, okay? Advocate. Advocate for your patient, right? Now, you can be firm and respectful as needed. So you advocate, and you assert when something's not going on, but it's not about you make me. If you got to say it makes me feel, you're getting personal. You state the scenario, why it needs to be addressed, without putting self into it. That's kind of the litmus. If it's getting personal, we're going into a different area. It's got to be about what we need fixed now. Now, 2-challenge rule. This is very interesting. It's important to do. Now, for this to work, though, this is why the physicians have to be trained with the nurses and the staff and the techs. Everyone has to train together because this is the cross-dialogue that's really important for feedback. It's a 2-challenge rule. So you have to be able to say it's called stopping the line, right? So if you say, they tell me to go ahead and give 10 milligrams of epinephrine IV push.
Please give 10 milligrams of IV push.
And I'm going to say, I question that order. That seems like a lot of epinephrine. And your response to me is, here's the rest of the script. I meant to say 10 cc's of 1 milligram and not be there. But anyway, that's the whole point of it, right? So that's what the person's going to say. In the 2-challenge rule, most of the time, it's not really a bad order, it's a slip. You think one thing and you say another, right? So I said give 10 milligrams of epi. I really meant 10 cc's of the 1 milligram IV push of epinephrine. And that's what the 2-challenge rule will fix. So one of the ER docs I worked with, we had a patient came in unexpectedly, and we heard it on the ambulance, and he was an asthma patient, was a family member visiting, and all of a sudden they rolled in, and he was in full respiratory arrest. Okay, suddenly we have CPR in progress, and we have to get this guy recovered. So Bruce Bowen, great ER doc, he's in Colorado now, rocking Denver, he goes, I need a trocar. He was Vietnam era. Trocar looks like a giant knitting needle. And they used to do that for the field in the 70s and 60s, late 60s, you would take a trocar like a giant knitting needle, hammer that through someone's chest wall to get the chest tube put in place in the field. The trocar. We don't use trocars really anymore. And that's not what he meant. He actually was meaning he wanted to intubate and he wanted a stylet. Right? You know the little wire that goes in the ET tube? That's what he really wanted. But he goes, I need a trocar. And 3 medics who were actually doing very valuable things with the patient all took off running. And it was kind of like you just hear them run down the hallway. But they're looking for a trocar, but they really know what they're doing. They just want to execute. You know, there they go again. Right? I'm like, why? I said, why do you want a trocar, for God's sake? He goes, I didn't want a trocar. I mean, I need a stylet. Yeah! Right? Well, that's like taped here, almost like on your ear right now. Oh, yeah. And he grabs it and goes. Right? It's about communications, because experts make slips and have lapses. Young people usually make errors. The end result usually is the same, but we call it lapses and slips. Or you guys call it getting old, right? But anyway, that's what it is. 2-challenge rule.
He says he woke up this morning feeling weak. Do you think we should see him today?
No, just tell him to stop taking the hydrochlorothiazide.
Dr. Diaz, I'm concerned about Mr. Johnson. I called and talked to him, and it sounds like more than just weakness. He sounded anxious, and he said he feels like his heart's beating out of his chest.
You know, you may be right, Renee. Let's get him in here today for an electrocardiogram and...
Now, this 2-challenge rule video, I'm glad it's not playing because you just want to slap her. But anyway, we'll move on. Now, here's the one you guys always remember. Everyone does really well in the test questions. Cuss. You like that one, right? It's easy to remember, and you guys, all of you, pretty much do this regularly all the time. So, I am concerned. I am uncomfortable. And this is the nuclear option. This is like that safe harbor. This is a safety issue. Any physician or senior nurse on that team will stop at I am uncomfortable. If you got to get to S, it's a big deal because we are about to hurt somebody. You understand that, right? When you say this is a safety issue, something bad is about to happen. And as a young nurse, you certainly want the nurse manager there, you want the nurse supervisor, because things are actually going to a place you don't want them to be. Now, 99% of the time, I'm concerned and then uncomfortable are usually going to be as far as you need to go. So be careful how you use cuss. Because when you get to S, we're really going somewhere, and it's going to require documentation. We're no longer about talking about it. We had a near miss or a miss at this point. Something is happening, and it has to be addressed. Because we had 2 other stops along the way, and everyone just, or the individual pushing the case has disregarded because remember, if everything's fine, but you're uncomfortable, don't I need to tell you something? If you say you're uncomfortable, and you're a new nurse, maybe this is something you're not ready for, right? So if I talk to you and tell you why we're doing it, now we've done some teaching and learning. And you're like, oh, okay, cool, right? Yeah. Or you're like, no, still uncomfortable. Right? So that means we need to really think about what I'm about to do here. That's called cross-monitoring, safety monitoring, and this also ties in advocacy and assertion, all in one little simple 3-letter, acronym. Now, desk script. This is important it doesn't happen real time. This is one of those things in an environment where we do counseling and cross-talking with each other in the environment of care. So what do you say? Describe the situation. And then you express the situation, and then you suggest alternatives to make the situation better, and then see the consequences. What's going up? What the outcome should be. Remember, consequence doesn't have to be negative. Consequence is just an outcome of actions. So, desk. That's a really nice way in an environment because in the military, you understand it's a rank structure, right? But you don't get fired. Here, you got to be very careful. It's a right to work state, right? So you can be fired for almost anything. So if everyone agrees to how you're going to have this discussion, how you feed yourself and or your family is not going to be put at risk if everyone agrees to this communication process. Because that is the hard part, to enter into conflict if they don't back you and it's a power coercive environment, right? That's the thing. So in the military, you get hollered at and stuff like that, but you still get a paycheck. Even if you're cutting lawn for a week, you still got money coming in, right? in the civilian sector. So this is very important when you guys interview. What kind of environment do we have? How do you resolve conflict here? And if they can't answer it and they do one of those things like this, oh, let's do a 360, and they kind of like look at each other and go like this, that means they don't have, and anyway, conflict is not a healthy thing in their service. And that should tell you a lot. Unless you really, really, really need that job, you might want to take a couple more interviews.
Hey, Karen, if you have a minute, we should talk about a situation from yesterday. Things didn't go as smoothly as we would have liked, and I feel some responsibility. So let's think about what we can do to make it.
Let me just tell you, this wouldn't be a good one.
Sure, Renee.
I was frustrated because the information you provided was incomplete and not helpful.
I'm sorry about that, Renee.
Well, I'm sorry we haven't provided you with the training you need. If we provide that for you, we'll all benefit. Now, I know you're new here, so here's what would be helpful next time.
So,
when a patient
it's
calls
even
with a
more
clinical
annoying in the
concern,
other one. Okay?
Ask some general questions, like the ones listed here.
All right, so, yes.
I thought you weren't supposed to bring like emotion, like I feel.
Well, it's not a good, I don't know how, you got to remember, you hired film crews that do some of these things, and they just make up their own stories sometimes under the best of intentions. But is that good resolve? Was that a good resolve? I didn't give you the training you need to be competent. So no, that was not good. I don't agree with that one at all. All right? So, and the other one's even worse, if you get a chance to look at it. But true collaboration is a process, not an event. So if collaboration's an event, something's wrong, right? If that, wow, we actually work together, that's a surprise. That shouldn't be. And I'll tell you, I've been in codes where I was like, wow, it was I like silent symphony codes, where really very few talking, everyone knows what they should be doing, and then the information you keep hearing is only when everyone needs to hear the information. Those are my favorite codes. Versus, oh my God, he's so pale. That doesn't help anybody, right? Oh, I can feel his chest breaking, right? Well, just do CPR. So communication. So we all know SBAR, right? You all know it well? Raise your hand. You can review this. Please don't make me go through it. Okay, thanks. So this is where she calls the physician. The physician hears the call coming in and is respectful because everyone's trained and she knows this nurse is going to follow the pattern of SBAR, so she doesn't say anything till after basically she goes through the whole piece, and then the physician and she then tweak down where they need to be on the care of the patient.
Hi, Dr. Feldman? Yes, this is Amy from 2 West. I've been taking care of Miss Everett. Well, she's an 82-year-old woman. She was admitted 3 days ago with DVT. She's on heparin, telemetry, and oxygen. She's been alert and pleasant with no problems other than urinary retention. And she has a Foley in place. But tonight she appeared confused. She's awake and oriented to person, but she thinks that she's at her aunt's house and that Ronald Reagan is president. Yeah. Well, no, I checked with her nurse from the last few nights and confirmed that she doesn't sundown and she's normally very sharp. Her heart rate has increased to 110. Her blood pressure is down to 110/60. Yeah, her systolic usually runs 150. Yes. Her temperature is 37 Celsius. She looks pale but not uncomfortable. Her coag studies are within the parameters and her blood gas is normal. All other AM labs are normal. She's not putting out much urine and it looks cloudy to me. I'm worried about her. I think she needs to be seen. Want me to order some labs? Maybe send her urine for culture?
Yes, sounds like she could be getting septic. Send a urinalysis with culture, chemistries, and a CBC. Thanks for calling. I'm on my way, but I need to know if there are any changes immediately.
So now call out. We used to put a question on, it was called HALA. Dr. Richardson pulled it because some students actually, because they were so amused by it, instead of call out, they would pick HALA. And they would actually like take a point off of themselves. They're just so tempted to do it. Some students say, I'm going to do that. So we don't put HALA on anymore as an option. Call out. So, who will work with me? Will you work with me? Will you read that script? You want to be the leader?
Airway status.
Airway clear.
Breath sound.
Breath sounds. Decrease on right.
Blood pressure.
Blood pressure is 96/62. So now, even though you were in the room, you all knew what the blood pressure was, and she controlled the input of information as she was ready to get it, right? That's a good code. Because information coming out saying blood pressure is 96/62, when you're auscultating breath sounds, that doesn't help anybody. So you controlled the flow of information, and we produced it as necessary. Checkbacks. So these are the tools, right? So go ahead and do a checkback with me.
Give 25 milligrams Benadryl IV push.
Give 250 milligrams Benadryl IV push?
That's correct.
Oh my God, we just killed him. So, okay, good. I said the wrong amount. Oh, the patient died. Oh, I should have been listening. Okay, you and I are going to jail. I know, you're reading your script. You stuck to the script. You did what you're supposed to do. All right, so check back. And this is this is a short video vignette between two docs. And they're just going ahead, basically did what we did, but correctly, and they ended.
1 gram of calcium gluconate diluted in 100 milliliters of normal saline IV for an hour.
Confirm that 1 gram calcium gluconate diluted in 100 milliliters of normal saline IV over an hour?
Correct.
Okay, handoff. The transfer of information. You all know the handoff is the most dangerous component in care, right? Because I have all the information I am to be comfortable with that patient, and then I'm going to give you the information you need, or do I? And that's the problem. Do I leave pertinent stuff off? And that's really important, right? So the handoff, knowing full well the handoff is a very, very dangerous time for a patient because information is now transferring with the patient. That's one of the areas in the CSI that we want to work with EMS traditionally when they do that handoff. Think about it. They usually extracted the patient, they brought in the patient, and now they're handing off the patient. And a lot of care has already occurred, and environmental issues and everything else. And a lot of times the nurses and the docs don't listen, and really important information gets missed. And that's where we want to create a scenario where if they don't listen to everything, that there'll be an unrecoverable error that occurs. Now, I got to say in Houston, when I was at Ben Taub, the nurses were vanguard for a silent room, and they let the paramedics talk until they got everything out that they wanted. Not just because they were firefighters, but because they had information. And I think maybe because they were firefighters too, I don't know. Quiet, he's talking. Right? But anyway, with that said, that room was silent. And I tried to recreate that at BAMC when I had the ED, and I was never quite able to get that kind of control over the room because it was a culture. In that Ben Taub, when those paramedics come in, nobody there. The third-year resident, nobody talks unless, somebody like get me a face shield because he's hemorrhaging on him while they're giving a report. But other than that, no one talked, and everyone listened, and full information. And I'm telling you, the amount of information, if they moved quicker, would have been lost, would have really changed the pattern of care. So handoffs, know that, drill that in. It's important. You have a certain way to do it, and there should be a checklist, like an SBAR checklist that's very comprehensive to make sure you go through this. And what we came up with initially was I-Pass Baton. Now, I think it's really good for students because it walks you through all the critical thinking junctures. But when the ER had to do this and hand off to the ICU, the nurse in the ICU always handed off right around the. Okay? That was it. Okay, whatever. So it was just too lengthy. They didn't see the value added in that lengthy of a formal report. So SBAR with comprehensive pieces added to it is really where most facilities are now. Now at Methodist, the pharmacy department actually writes all their memos to the docs and nurses in SBAR format. And it's really important if you start to talk that way, start to prepare to listen that way, it really works well. And I-Pass Baton, great video, but it takes like 20 minutes. So.
Lucinda. I'm going to need you to step in while I get Dr. Smith. Eddie's complaining of new onset chest pain. His BP is 90/65, heart rate 110. He looks pale and diaphoretic. Peg's getting his 12 lead. He has his oxygen. He's having an MI. Get him on a monitor, start an IV. I'll be back with Dr. Smith in 2 minutes.
Oh no, poor Eddie. Has he had anything for pain?
No, that's something you can work on. Dr. Smith, I have Eddie Thomas in room 6.
Hold on.
Eddie Thomas, 56-year-old with congestive heart failure, multiple ED visits.
Yeah, I'll tell you what, 40 milligrams of Lasix IV, O2. I'll see him as soon as I'm done with these dispos. Got to clear some rooms or we're going to be back on the verge.
Dr.
So
Smith,
listen,
I'm concerned.
All right, look, I'll have to call you back. Okay. Yeah.
Eddie isn't presenting with his usual heart failure. He has substernal chest tightness radiating to the jaw. He looks pale and diaphoretic. BP is 90/65, verified with manual cuff, pulse 110. We've got him on O2. We're getting a 12 lead starting a line. I think he may be having an MI. We need you to see him now.
Based on what you said, sounds like it might be an MI. All right, I'm on my way. What would you say, room 8?
Room 6.
Okay, room 6. Got it.
Right.
Yeah, here's his electrocardiogram.
Oh, this looks like it could be an acute MI. All right, everybody, hey, let's huddle up before we go in so we know what we need to do.
Well, I've got the 4 liters O2 by nasal cannula and 2 aspirins. He's hypotensive, so we might want to drop the nitro. He's already on the monitor.
Good catch, Karen. Hold the nitro. Where are his cardiac labs?
His labs are pending. We should have those in 15 minutes.
Okay, let's prepare to get him to the cath lab immediately.
I'll call the cath lab to confirm.
Okay, all right, let's get in there. Eddie, you're having chest pain, you said?
Yeah.
Eddie, I'm worried this is not your usual heart failure. I'm afraid you might be having a heart attack. Now look, a lot of things are going to happen over the next few minutes, but then I promise we'll have a chance to talk. Okay? All right.
The chest x-ray's here. The cath team confirmed they can take Eddie in 5 minutes. Dr. Martin's on line 3 for you.
Okay. I'll be right back. Thanks, Al. Hi, Bob.
Hey, Bart. Is this your idea of putting me on a diet? Because every time I put food in my mouth, I got a new ER case.
No, just trying to keep you busy. Actually, it was Hal that made a good catch on this one.
Tell me more.
Well, this is Eddie Thomas, 56-year-old gentleman with viral cardiomyopathy and frequent episodes of congestive heart failure. We know him well. Today he came in with an acute anterior MI and early cardiogenic shock. We do have his new and old electrocardiograms. He described the pain as ripping, and his history is one of viral cardiomyopathy, not coronary artery disease. So I'd consider squirting his chest to be certain there's no dissection. He's had aspirin and heparin. We're starting integralin, and there's no beta blockade or nitroglycerin on board because of his hypertension. His labs are drawn and pending. So I'm going to sign off. I mean, Hal will be here to make sure you've got everything you need.
Okay, Bart. You have a recurring heart failure patient with new onset atypical chest pain. Electrocardiogram findings are consistent with acute MI, aspirin but no nitro, and labs pending. I got it from here.
Hey, Hal. Good job with Eddie earlier today. You know, our communication was precise, and we got him the necessary attention quickly. Good job.
Here we go. Here we are. There it is in a nutshell. Essentials. Okay? I just did an hour and a half in an hour. So, we're on schedule. But you guys are going to have to go through this and work with it. And that's why we're going to do the scenarios after a quick break. But this is where we're at. Team structure, leadership, situation monitoring, mutual support, and communication. What elements do you, as the nurse, doctor, tech, or even clerk, bring to this scenario? What are the 3 things that you bring to the table? The what? Performance. Attitude. Knowledge. 1 out of 100 of you got it. One more time. What are the 3 things you bring to your interview? There, let's make it matter to you. Before you get your job, what are the 3 things you bring to the table? What? Performance, attitude, and knowledge, right? I'm just kidding. You guys are actually very bright, and you're going to bring a lot to the table, and you're ready for this. So these are the barriers, and here, when we go to the scenarios, these are the tools you should be able to find in your guide. And there's the outcomes. At the very bottom, most important though, patient safety. Patient safety. So go ahead, take 10, shake it off, come on back, and let's do some scenarios. Okay? Any questions?